Hello, everyone. Thank you for being here. I think we'll go ahead and get started. My name is Mary Ellen Maher, and I'm the advanced practice nurse in neurosurgical oncology at the Malnati Brain Tumor Institute. I didn't do this alone. I would like to thank my co-collaborators. Sitting up front is Laura Jarros, Caitlin Connors, Eliza Delgado,
getting
Chris Balmacetta, and in the back, and Meg Schwartz is incognito, online. So again, thank you all for being here in person. So we have a large audience that's also here via Zoom. And I heard rumor that it was like 19 states so participating in this. So we're really excited to have kind of spread out to that broad audience. But on behalf of Dr. Roger Soup and Dr. James Chandler, the medical and surgical directors of the Malnati Brain Tumor Institute, we again thank you for being here. We have a few housekeeping items, food and more food. So please make sure to come up and get your first, seconds, and thirds helpings. There's drinks on the second station. And I think cookies are back there too, for some of you that really just want the cookies. Or the restrooms, male and female, are just across the way. We do ask that those that are here in person, if you have questions, submit them to my left side over this way. And Chris or myself or Caitlin will pick them up, and then we will work towards getting all of your questions addressed that way. Those of you that are online, we ask that you submit your questions via the chat, because at this point you are muted. So please submit any questions via chat. After this meeting today, you will be emailed an evaluation. So please help us to plan for future events. We really appreciate any input that you can help with providing to us, how we thought this event worked, what kind of information you'd like to hear would be very helpful. Did everybody get parking? Anybody need parking? Eliza at the front desk or Terry can help you with parking. No takers on that. Okay, so kicking off, Vince. So Vince Rock is here representing the American Brain Tumor Association. He's just gonna do a few minutes of your time today in expressing all of the things that the ABTA has worked with us and helped many patients with that are brain tumor survivors.
I might need a lesson on how to use this thing.
Oh, well, you can also just use the arrow.
Like that? Oh, okay. That's how it works. Lesson over. All right. Hi, everyone. I'm Vince Rock. I am a senior program manager with the American Brain Tumor Association. I'm also a licensed clinical social worker. I'm really grateful to be here today. The ABTA has had a really great relationship with Northwestern for many years, and really glad to be able to continue that partnership. So thanks so much, Laura, for inviting me, and the rest of the team too. So I'm just going to give kind of a brief synopsis of our organization in case you're not familiar with us, and then talk a little bit about some of the services that we offer that you could benefit from. So if you're not familiar with our mission, it's to advance the understanding and treatment of brain tumors with the goals of improving, extending, and ultimately saving the lives of those impacted by a brain tumor diagnosis. We deliver on our mission in two significant ways. One is through funding really important critical brain tumor research. That's something we've been doing since day one of our organization. And the other part of our mission is to provide services to people diagnosed with a brain tumor, as well as their loved ones. We are a not-for-profit organization. We've been around for 50 years, celebrating that anniversary this year. We're really grateful and glad for that. And all the services that I talk about today are offered at no charge, thanks to the generosity of our donors. So let's talk about a little about some of the programs that we offer. Our oldest program is called our Care Line. This is our phone and email information and resource service. So through our Care Line, people can call us during daytime hours, Monday through Friday, 9 to 5. They get a live human being on the phone. I happen to be one of them. I'm one of 3 members of our team who answer the phones. And we have conversations with people who are looking for information or resources. That could be looking for information about brain tumors. We get called by a lot of people who say, you know, I was diagnosed with something called a meningioma. What is that? What can you tell me about that? And we have lots of really wonderful resources. I know it's called meningioma. A lot of people get it wrong. And a lot of people also call us looking for social support resources. As you know, this is a rare disease, so it can be hard to find people in your community who can really relate to what you're going through. So we have a lot of great resources to help connect people so they can find others who can really relate. A lot of people call us also about finding treatment center opportunities. Maybe they don't know where the nearest brain tumor center is, or they live in a rural, kind of remote area. We can help direct them to really top-notch, high-quality institutions like Northwestern and others that specialize in brain tumors and serve that population incredibly well. We also get a lot of calls about financial assistance. As you know, this is a disease like other cancers that causes a lot of financial toxicity. A lot of people have to stop working, medical bills. You know, we've heard it all at this point. While we don't provide financial assistance, we can refer people to financial assistance resources that operate nationally and locally as well. So people can call us, like I said. We also take emails, and we sometimes respond to people's requests via Facebook as well. One of the programs I manage is our patient and caregiver mentor support program. This is a volunteer-led peer support program. The way this works is we have mentors, well over 200 of them. These are people with actual lived experience with a brain tumor. They're either patients or survivors themselves, or they're current caregivers or have lost a loved one diagnosed with a brain tumor. And these are people who are at a place in their life where they're ready to support others who are maybe newer to the journey for one-on-one conversations. So when people call us and say, hey, I was diagnosed with this tumor, I can't find anyone who has it. Can you connect me with someone? Or, my husband was diagnosed with a tumor. I'd like to talk to someone in a similar situation. We can make that connection happen through the use of our wonderful volunteers. The way people usually communicate is by phone and email, sometimes text message and video chat. I've seen lifelong relationships form out of this program. As you can see on the right there, we've made over 1,000 matches since we started this program in 2015. So we're really proud to be able to connect people in the brain tumor community. And a little anecdote, last year I gave this spiel to the same crowd, and it turns out one of our mentors was in our audience. So if there are any mentors here today, hello online, glad you're here. All right, let's go to the next slide. A really great resource we offer, and it's a little bit newer, is called our Treatment Center Guide. This is a database of brain tumor treatment programs throughout the country. So there are a lot of hospitals that will treat brain tumors, but they don't necessarily specialize in it. And of course, when you're diagnosed, you want to go to a specialist. You want to go to a place that offers comprehensive care, like Northwestern. So what we do is we survey a large number of institutions in the United States. We collect really rich data from them. We ask things like, how many specialists do you have? How many neurosurgeons, neuro-oncologists, radiation oncologists do you have on staff? How many people do you treat a year for this disease? What kind of treatments and technologies and support services do you offer? So we collect all this information, we make it available on our website so that people can make more informed decisions about where they're seeking treatment. You may be familiar with some of our educational materials. We offer brochures that discuss some of the more common brain tumor types as well as treatment options. We also have resources for, see if I can get this right. There we go. Caregivers. We have a caregiver handbook. We also have a handbook for the newly diagnosed. So if you're newly diagnosed and are wondering, what do I do next? That's for you. All of our brochures are reviewed by medical experts, so they're accurate and up to date. And they're offered at no charge. We'd be happy to mail you a set of brochures if you like. Just go to our website for that or call us. You can also download them from our website if you want a digital version. We're actually working on getting these translated into Spanish next year, because we're seeing an increasing need in the Spanish-speaking community, and that's a group we really want to serve. We also have an online support community called Connections. The way I'd like to describe this to people, it's kind of like a Facebook group, but in my opinion, I think it's better for a couple different reasons. First of all, it's private. You know, on Facebook, your name is seen on every post, right? And other social media too. But on this platform, you can create a username that has nothing to do with your legal name, and you could have that privacy and confidentiality that a lot of people want. Second, it's moderated by professionals and volunteers to make sure that the community is safe, that there's no inaccurate information being shared, and that people are just generally respecting and caring about one another. And third, we offer a really wonderful opportunity called Ask the Expert, where a few times a year we'll invite a clinician or two in to join the community and answer questions on a specific topic related to brain tumors. We've had, over 36,000 members join. At any given time, about 2,000 members are very active in our forum. So come check it out. It's a great way to find other people who have similar experiences to you. We also offer a virtual webinar series. This is a 60-minute live webinar that we feature about once every 2 months or so. We got one coming up on Wednesday if you're interested. It is called Navigating Your Brain Tumor Care. Really appropriate topic. I'll actually be hosting it in place of my colleague who's on time off right now, well-deserved vacation. And the way these webinars work is we invite an expert in, and they will talk about a specific topic. And at the end of the live broadcast, anyone who's attending can submit a question that the physician can answer at the end. You don't have to attend the live broadcast to access it, though. You could always watch all of our webinars, all of our conferences on our YouTube channel for future viewing. We've got webinars going back years and years that are full of really wonderful information in case you're interested in that. A couple times a year, we offer patient and family meetings. These are kind of like our webinar series, but bigger and better. So we'll take a topic like, let's see if I can get this to work, adult low-grade gliomas we did in March of this year, or brain metastases we did in June. And we'll invite several different researchers and clinicians from throughout the country to speak on various aspects of these diseases. It is a virtual offering that it's usually a half-day event. And we realize that no one likes to be sitting on Zoom for half a day getting talked at, so we try to make these as interactive as possible. We include things like mock tumor boards, short support groups, roundtable discussions, breakout groups for people to meet and interact with each other. So it's a really cool way to get in touch with the community and learn a lot of really cool things at the same time. And you might have heard, if you signed up with us on our email list, our national conference. This is our big signature event that we do every year. We just had one a little over a month ago, and it was really wonderful. We had hundreds of people attend, and it was just a really beautiful way to see the community come together, learn, connect with each other. We do this every year. We do it both in person here in Chicago, and we offer it virtually as well in case traveling to Rosemont is not an option, as it is for most people in the country and even the world. We get international attendees too. We're just starting planning for our 2024 national conference, so if you want to learn more about that, just sign up on our website. Okay, I'm going to pass through that in the interest of time. Our website can be translated into Spanish. Just look for the little flag on our website in case you know anyone whose first language is Spanish. Okay, and I'm going to talk very, very briefly about research because that's such an important part of our mission. I'll just give some of the high-level overviews, which is that we've funded over $34 million in brain tumor research since we started in 1973. We've affected a lot of researchers. Actually, one of the speakers tonight was an ABTA grantee at one point. So we're really proud to be able to continue supporting this community and helping to advance the understanding and cure of brain tumors. All right, we are a nonprofit, so we have to fund what we do, and we do that in really fun ways. Some of you may be familiar with our 5K that happens every spring. We do it in Maggie Daly Park. We offer 5Ks throughout the country. We also do a virtual 5K in September as well. Going downtown is not your thing. or if you don't live near any of these major metropolitan areas. But I've gone to the 5K every year that we've had it since I started at the ABTA 8 years ago. And it's just a really cool thing to see people come together, walk or run in honor of someone they know who's diagnosed, someone who's passed. It's just really beautiful to see the kind of spirit of people coming together for something like this and raising money for a great cause too. We are a small organization and we do a lot with a little, so we rely a lot on volunteers. If anyone is interested in volunteering, please feel free to contact us. You can email volunteers@abta.org. We would love to have your support in any way possible. Okay, we are on many of the major social media channels like Facebook, Instagram, and Twitter, or X, I think it's called now. We also have a newsletter called Mind Matters if you're interested in learning what's going on with our organization and the brain tumor community in general. Okay, I'm going to stop there. I don't think there's time for questions, but what I'm going to do is I will be in the back of the room afterward today or during a break. If you have any questions, please feel free to come up to me. I'd be very happy to support you in any way that I can or anyone that you know. Again, all of our services are offered free of charge, no cost to anyone. So please take advantage of what we offer and please help us spread the word. Thanks so much.
Thank you, Vince, for being here. It's great to know such a great organization is kind of like out our back door. It's right here in Chicago, and that they offer many opportunities for us to learn more about brain tumors and share with others. So thank you again. I'm pleased to be able to introduce Dr. Adam Sonovan. So I forgot to print this out. So Brianne was very nice and figured out how my phone wouldn't close out. So here we go. Dr. Sonovan is an associate professor in neurological surgery and leads Northwestern's Hispanic brain tumor program. Dr. Sonovan's clinical focus is the surgical management of tumors of the brain and skull. He also oversees a basic science lab, which conducts translational research that aims to improve the survival outcomes of patients living with a glioblastoma. Dr. Sonovan's main research interests are in understanding physiology of the blood-brain barrier and facilitating the delivery of chemotherapy to the brain. So everyone, please welcome Dr. Sonovan. And while we have 2 seconds, if anybody wants a second, third, whatever, for snacks or the dessert time or refreshment with some water, please help yourself.
Sorry, everybody. You might have to give me 1 quick second. We're in a page IT. It's showing on the Zoom, but not in the room.
Very nice to see you all anyway.
Thank you. Yeah.
That's the other option we can do if you want to disconnect the HDMI to it. You want to do it?
He's right here.
Okay.
So it's sharing on the Zoom, but it's here.
I can also open an HDMI. Is the monitor?
This is the Zoom. This is the computer, but it's not showing here.
Image. Sharing the Zoom. Would it be this one? No, just go with the Zoom.
Yeah.
Oh, that's right. So I just need to move Zoom over there. Perfect. There we go. Good. All right, well, I really appreciate the opportunity to talk to you today. As Mary Ellen was saying, I'm one of the neurosurgeons here. I specialize in the care of patients with brain tumors. And I'm also a brain tumor researcher. And so my ideal job situation is when both worlds collide and I do best patient care by offering patients something that I might consider full of hope and innovative. And while I take the opportunity of caring for patients to learn something about the disease so that I can benefit other patients in the future. So that's where I live, somewhere in the interface between doing research and working on managing and treating patients. And so today I want to talk to you about the blood-brain barrier. And I want to make the argument that this is something that is super important for glioblastoma. Can you all see this is working out well? Good. All right, so let's see if I can. Okay, so start with some humbling statement. Yes, I know neurosurgeons have big egos, right? That's something you never heard of. And what you will learn is, as a neurosurgeon, you might have interacted with one of us at some point. First thing is we show up and you might have a tumor and we are the ones to say, we're going to do this surgery. It sounds somehow provocative that we're removing something and patient's doing well after surgery. And our morale is really high because somebody came in with a problem and they go home with a nice looking MRI. And maybe they came in with a deficit or some symptoms and they usually get better. And so that's really nice as a surgeon to feel that I can remove the tumor in a very simple term. You see this MRI on the left. There's a tumor that shows in white, and on the right, you don't see the tumor. So good looking scan, patient feels great, goes home. But unfortunately, we have to acknowledge a limitation of the fact that as a neurosurgeon treating patients with malignant gliomas, surgery plays some role, but it's not groundbreaking. And so what we can do with surgery is do things like provide a diagnosis, so give the tissue for the pathologist to really provide a good diagnosis. We can make people feel better. We can get the pressure away from the brain so that the symptoms can improve. We can even remove most of the tumor so that the oncologists are stuck with less tumor cells to deal with. But unfortunately, the one thing we cannot do is be radical and remove all the tumors. And the nature by which this is the problem is because these tumors are called infiltrative gliomas. And really, in simple terms, what makes an infiltrative glioma an infiltrative disease is the fact that there's no real boundary where the tumor stops and the brain starts. I hope you can appreciate here, these dark brown cells are the tumor cells, and this is the brain. And I always think of it a little bit like an iceberg, where there is the part of the iceberg that you see above the water level, but there's unfortunately some things that you don't see that are underneath. And the water turns out to be the brain, so you can't just completely remove the water. And so here you see an example of a tumor cell that has infiltrated. So no matter how good the MRI looks after, we always universally consider the patient to have some residual tumor cells. So that's the limitation of surgery. And the problem is that these residual cells are hidden in the brain. And the brain itself has this really elegant structure called the blood-brain barrier. The blood-brain barrier is an arrangement of endothelial cells that basically form the tubes of the blood vessels. And these endothelial cells look a little bit like my fingers intertwined, and they form this really tight arrangement where there's almost nothing that can get through. Most of the things that can get through because there's specifically a very narrow, really specific door for these molecules to enter, like glucose, some amino acids, and different things. Oxygen can get in. But for the most part, 95% of the molecules that are in the bloodstream simply don't get into the brain because of it. If something happened to get into the brain, this is crazy sophisticated. There are pumps that would grab it back from the brain and pump it right back into the circulation. So there's actually an energy-dependent mechanism to keep things from getting into the brain. This is seen across multiple species of animals. And why is all this so sophisticated and so conserved? Well, it's to keep our brain from getting intoxicated. As you know, when you eat something you're not supposed to, you get sick, but for the most part, it almost never gets into the brain. Exceptions to that are obviously alcohol and other things that do cross, but for the most part, things don't get into the brain. And this turns out to be super inconvenient when it comes to treating brain cancer, where these tumor cells are hidden in the brain. Because the chemotherapies that we use, the antibodies that we might use, are perceived by the structure as toxins, so they're not getting in. The problem with that is that there's not that many drugs that are developed for brain tumors. Most of the oncologists rely on drugs that are developed for other cancers, and we take them off the shelf and we use it for brain tumors. There's several reasons for that. One of them is economical. You know, developing a new drug might be about $100 million and 10 years worth of time investment, and it's very risky. Most drugs that are developed never make it through. So the drug companies often say, well, let's do a drug for breast cancer, where we might have 1 million patients, right? But if you talk about glioma, there's only 30,000 patients or so a year. So it is actually not something that companies often do, to develop a drug specifically for brain tumors. So we're stuck with the drugs that were developed for something else. And if we can only use 5% of those drugs that get across the blood-brain barrier, obviously the repertoire to treat brain tumors is rather limited. So what I have been working on is a new technology that allows you to take drugs that are already being used elsewhere, that are already FDA approved, that are already being routinely administered, the doses are known, to actually get them across the blood-brain barrier. And so I'm going to show you today a little bit about how this works. This is a technology that I wish I could take credit for. It is not my technology. It's a principle and approach that's been developed over the last 15, 20 years. It was first shown in rabbits and in mice and in rats. But in order to jump into humans, there was a huge problem that needed to be overcome. The problem was that this technology relies on sound waves. And the human skull is much thicker than the mouse skull. So for sound to go through the human skull, there's a huge problem, right? And so the technology I want to show you today relies on ultrasound emitters, that you can see them right here. It's a grid of 9 ultrasound emitters that are loaded on a mesh made out of titanium that is sitting underneath the skin instead of the bone plug. Meaning, we made an opening in the skull to remove a brain tumor. Instead of putting back the bone that we took out, we put this mesh back in there, and the mesh has underneath it all these ultrasounds. And you have a port, and when you want to turn the ultrasound on, you put this needle connected to a cable and an energy source, and the needle goes only through the skin and connects the energy to these ports so you can activate these 9 ultrasounds. So what I'm showing you right here is a CT scan of one of my patients that I routinely get after surgery. Many of you might have seen patients get often staples to close the skin. So you can see here the suture line and all the staples that I use. And underneath the wound, you'll see that there's this ultrasound machine. So let me show you how this works. And bear with me, the video, this is a cartoon. It's a little slow, but I think it tells the story well. So here's the skull. I open the skull, and you can see here the top of the iceberg that I can remove, but the surrounding brain, you see dark blue, has some tumor cells in it. We go ahead and we screw in this ultrasound with the mesh into the window in the skull. We close the skin, that you'll see there in blue. We after that inject into the vein these tiny little microscopic bubbles. And these bubbles are actually already FDA approved. They're used as contrast ultrasound agents. And when the bubbles are going into the tiny little blood vessels, you see that the endothelial cells are arranged very tightly. The white stuff are the bubbles, the red are the red blood cells, and bloodstream, and we go ahead and we connect this ultrasound device with the needle, and the sound is suddenly projected at the brain. You can see there the sound waves going in and hitting the brain. You should know the sound waves have the same energy as the obstetric ultrasounds we use for babies, so pretty harmless. But then suddenly the sound waves start hitting these bubbles, and the bubbles start oscillating because of the sound. And as they oscillate, they just open these tight junctions. And suddenly, if you inject chemotherapy, that shows this very cool green color here, it gets into the brain, then it gets into the tiny little blood vessels in the brain. And because these openings are now present, you can suddenly get into the brain. So that's how this technology works. If you think about it, it's really not that complicated. Have sound, have bubbles. Bubbles are going through the little blood vessels, and the sound waves make the bubbles oscillate. If you take advantage of that to then inject chemotherapy to the veins, it suddenly can permeate into the brain. And so that's how this technology works. I'm going to next show you a video, and I asked Laura for a blessing on this, because I want to show you a video of the brain of one of my patients. And so let me explain. In order to determine whether this works, do you actually get chemotherapy into the brain or not? What I did is I conducted this clinical trial along with my colleague Roger Stu. And when there was a need to go through some brain to get to the brain tumor, we had an opportunity to see whether this technology was indeed getting the drug levels up in the brain. As you might know, sometimes the brain is isolated from the rest of the brain because of the tumor, or sometimes there's non-eloquent brain. That means there's redundant brain that other parts of the brain can take over that function. And as surgeons, we need to go through a little bit of brain to get to the tumor. And so we took advantage of that in order to do this study. So this is the frontal lobe of one of my patients. You see it right here. And I have just finished turning on the ultrasound device. And I have injected the microscopic bubbles. And I'm about to inject a dye called fluorescein that is green, that simply doesn't go across the blood-brain barrier. So with the microscope, you see all these little blood vessels. We're about to see the vessels turn green. Let's see if it works out. Yeah. So you'll see suddenly the fluorescein going into the arteries, but not in the veins. Within a few seconds, it's going to be in the capillaries. So every tiny little blood vessel in the brain will turn green. And as time goes, you're going to see the arteries that are pulsating, like you see right here. They're being washed from the fluorescein, because the fluorescein now is in the veins, and the kidneys are going to start just basically washing away the fluorescein. And as this happens, the brain starts bleaching, and it's no longer green. And this part of the brain, for instance, right here, as we speed up, you'll see it'll be less and less yellow over the first few minutes. But there are two wheels that you see at the top. I hope you can appreciate those, right? So those two wheels where it looks intensely green are the parts of the brain where I actually was focusing the ultrasound. So you can see we were able to get a lot of this dye into the brain. So you visually can confirm that the brain has been made permeable. You can see this top part is also green. You might wonder why. That's the part of the brain tumor that came all superficial. So in the case of a glioblastoma, the tumor core does not have blood-brain barrier, but that's the part that I have to remove anyway. This other part is, relatively speaking, not gross tumor, but I can get a lot of drug and a lot of fluorescein to get in there when you hit it with the ultrasound. And so we also look at the same thing to understand how deep can we get with an MRI. Because it turns out when we're done with surgery, we finish removing the tumor, we implant the ultrasound device, we close the skin, patient goes home, and it comes back about 2 weeks later, ready to start treatment. The beauty of this approach is that we can open the blood-brain barrier in the clinic, in the outpatient setting. The procedure takes about 4 minutes, and give chemotherapy. And we do this over every 3 or 4 weeks. When we're doing that, The first time around, we also do an MRI. And as you know, MRIs are done with gadolinium. And wherever there's gadolinium in the brain, it will look white. And that really shows you the parts where the blood-brain barrier is not really intact. So if you get an MRI on these patients before the ultrasound, you'll see there's very little white here. But as soon as the ultrasound is done, you see the whole temporal lobe turn white. So you can actually see what parts of the brain are being targeted and what parts of the brain are being permeated to drugs. And so that's a demonstration of that. So by doing this in several patients, this is actually the example of the video that I showed you. This is a large tumor, the right frontal lobe, and you can see just superficial to it, the brain that looks dark, meaning it's infiltrated by tumor cells, but it's not really grossly tumor yet. And so that's where I did this study. And in these patients, if you look at the chemotherapy drug that we use, in this case, we use a drug called carboplatin. There's about a 9-fold increase in the concentration of carboplatin in the brain for these patients. We tried 2 separate drugs. One of them is called paclitaxel, and you can see here, this is the part of the brain that is not sonicated in red and sonicated in green. There's about an almost 4 times increase in drug levels for paclitaxel. Paclitaxel is a very good drug, but simply not used for brain tumors because it doesn't go across the blood-brain barrier. Same thing for carboplatin, we see here 5.9 times increase. So we're doing multiple time increases of drug levels in the brain with this technology. And we can do this every few weeks, and patients actually tolerate this pretty well. We've finalized a phase 1 clinical trial looking at what's the best dose to do and whether this is safe for each of these 2 drugs. And those studies are done. Now what we're doing is we're conducting a clinical trial where we're combining both drugs at the same time on every patient, and that's a study that is currently ongoing. But there's also another aspect to brain tumor challenges as far as from therapy that we're trying to address. And this is the fact that not all tumors are equal. And so when you look at whether a treatment works for a given patient or not, what we do, traditionally speaking, as scientists, as doctors, is compare 2 groups of patients. We flip a coin. Some patients get the treatment, some patients don't get the treatment. And we hope to see that the patients that got the treatment will live longer than the patients that didn't get the treatment. And so when you do that, this is the traditional hypothesis that you have. And I'll show you here something that is very commonly looked at by the doctors. It's what we call the survival curve. So in the x-axis, you have time. On the y-axis is the percent of patients that have had an event. The event could be the tumor growing or survival. And what you'll see is that the traditional hypothesis is that the patients that were treated, maybe the red group here, will shift to the right? So they might live longer no matter at which point you look at it. But the reality, a very common thing that happens often is that they don't really necessarily, for the most part, if you just separate them into 2 groups, live very differently. But there's always a few patients, maybe 40% or so, they might just have a really nice durable response and live for many years. And the traditional clinical trial design is not designed to take that information and translate it into whether this patient benefit or not. And so that's the other aspect of what we do in the lab and that we're combining. For instance, this is the case of immunotherapy. Immunotherapy with PD-1 blockade is an antibody. You probably heard about Jimmy Carter being in remission after having this very late-stage melanoma. A few people got the Nobel Prize for this. It was probably the biggest revolution in cancer care in the last 20 years. A lot of people did really well in other cancers. And so we started doing this in patients with glioblastoma. And I was routinely given this with my colleague from Colombia, who's an oncologist. And I was operating on all these patients with recurrent glioblastoma, so we'll give them PD-1 blockade. And many times, unfortunately, it was pretty disappointing because it wouldn't work. But there were a few cases where we really noticed that we made a difference and patients would be alive for years. And what I can show you here is we discovered this biomarker that you can stain in the tissue that, as you can see here, it will look brown when the staining is positive. And so here is a patient of mine, and did this very large resection here. And then we started the treatment 2 weeks later, and then 10 months later, there's a little bit of something growing, it appears to be tumor. I was able to take some of that out, and it turns out there was no tumor cells whatsoever. There were only T cells that were recognizing and killing the tumor. And the patient went on to live for another 21 months until we lost to follow up this patient who was not from this country. There was another patient who unfortunately did not have the biomarker, and we started treating the patient, and unfortunately 6 months later, the patient passed away. So there are ways we're investigating to tell who might benefit from what treatment, even if the treatment doesn't work for everyone. And so we're trying to shift away from thinking that in order for a treatment to be valuable, it has to help everyone. Maybe if we find 3 or 4 treatments that between them, they might help most people, we already made a huge advancement, right? So the same survival curves I was talking about, here you can see in red is the survival curve of the patients that had the biomarker, that had the treatment, so you can see they clearly live longer. But in the absence of treatment, you get the purple, then the patients do not live any longer than the other patients. So I want to stop here. I just wanted to give you a quick snapshot of things that I consider encouraging and promising, and yes, to some degree preliminary, but already at the clinical phase, which is the intersection between getting drugs to the brain, which might sound very obvious, but without drugs in the place where the tumor is, it's very hard for drugs to do anything to the tumor. And finding out how to define success and how to tease out which treatments might be effective, even assuming that they might not work for all patients. And so these are the 2 things that are the pillars of the work that I'm doing in my translational research efforts. So as future directions and opportunities, we have open clinical trials investigating this approach for treatment of all sorts of brain tumors. There's clinicaltrials.gov, as you know, there's several clinical trials available there. We are incorporating now the biomarker and the delivery strategies to at least 2 separate kinds of brain tumors, some with chemotherapy, and can't say yet that hopefully we might be weeks away from starting similar study with a very exciting form of immunotherapy for these tumors. And of course, if this technology works the way it seems to be working, it might open the possibility for repurposing other drugs to treat other brain diseases that are not cancer, right? And so last slide is probably the most important, which is the one where I really explain that I'm presenting this on behalf of a large group of people that are super smart, very hardworking, and a lot of great collaborators, and obviously very generous philanthropy support, as well as some NIH funding. Anyway, I'm going to stop right here and just let you see if there's any questions I can ask.
Thank you very much, Dr. Stanovic. Does anybody have any questions? If we could write them down, Chris is right there. If those of you that are online can submit the questions to the chat room, we're happy to pull them off of the computer and forward them. And
so we do have a couple questions that are coming through the chat. The first one is, what is the risk of infection by using the mesh clothing versus standard care?
Yeah, it's a great question. There's clearly a risk of an infection when you put a foreign object and then you stick a needle through the skin. I am pleased to say that so far in my clinical trial, I have not had an infection during the clinical trial. It's going to happen sooner or later. But so far, in the context of a clinical trial, we have not had this.
Thank you. Good news to hear.
Yeah.
So far. And then, although you didn't cover vorasidenib, do you have any information on the expected availability for the public?
I do not have information on that, but I look forward to it. All right. Thank you.
our next speaker I'm pleased to introduce is Dr. Jessica Templer. She's an associate professor in neurology and an epileptologist. Dr. Templer is board certified in neurology and certified in clinical neurophysiology, epilepsy, and neurology. She trained at Rush and Northwestern and has been a faculty member at Northwestern for over 7 years. Dr. Templer is also a leader and founding member of Northwestern's novel low-grade glioma program. We're pleased to have Dr. Tepler speak to us today about seizures and brain tumors. Thank you, Dr. Tepler.
Thank you very much for the invitation. Can you see me okay? Am I good on this? Okay. All right. So thanks so much for the invitation to speak. I just wanted to give a little background. I just want to give a little bit of background on myself. So I'm a neurologist, and is this good? Are we good?
Yeah.
Okay. So I'm a neurologist, and I specialize in epilepsy. So I specialize in seizures and the management of seizures. But within the world of epilepsy, I specialize in seizures that are related to brain tumors and lesions in the brain. And so as part of that, I'm part of the Lurie Malnati Brain Tumor Institute, but I'm also part of our Northwestern Comprehensive Epilepsy Center. So this allows me, it gives me a unique perspective, given that my background is really epilepsy focused, but I really rely on my neuro-oncology and neurosurgery colleagues to help guide me through the world of brain tumors and also my patients. And I've learned a lot over the last nearly 10 years of learning about this, but also bringing the seizure component to this and talking a little bit more about that and the role it has for my patients with brain tumors. I'm going to talk a little bit about what is a seizure, why do they happen, how do they relate to brain tumors, some seizure medications, seizure safety, and just some final points. For any of you that are my patients, or if you've heard me speak, I always start by talking about what is a seizure. Oftentimes, if somebody has gone to the ER, they'll say, you had a seizure, but no one ever talks about what a seizure is. They'll say, we're going to put you on seizure medications, but nobody says, what do seizure medications do? So I like to start from the very basics and talk about what a seizure is. So the brain is made up of these cells called neurons. And the neurons, they fire whenever you want to do something or say something or you're thinking something. And so anytime in your brain you have this organized chaos, which is what lets us be able to walk and talk and do things and be the complex humans that we are. However, when a seizure happens, there is some misfiring neurons. So there's a part of the brain where the neurons are misfiring, and it's sort of a spark. And so those little neurons, usually it's around where a tumor was before, around where somebody had surgery. They start firing, and they don't cause a problem right at the beginning. They just are sitting there, and then they start recruiting nearby neurons, and those nearby neurons start causing symptoms. And so then the more neurons that you have that are activated, the symptoms kind of change. So in the beginning, if the seizure starts in the part where the brain is, the part of the brain that controls the hand, it may be something that's just fire, 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 and there's just this little twitching of the hand. And that's it, and then it may stop. But if the seizure spreads and those neurons recruit nearby neurons, then the seizure spreads and it could control, then it starts to spread to the part that controls the hand, and then the arm, and then the face. And so as the seizure spreads, people can have different symptoms. So a lot of times the first thing I'll ask is, what was the very first thing that you felt when you had a seizure or when you felt something coming on? And people are like, I don't know, I felt a little something. And I'm like, no, tell me. It's like I'm interrogating them as I'm like, no, what was the very first thing? Because that's usually a warning sign that we can reliably follow to say, hey, this part of the brain is misfiring. This part of the brain is irritable. Let's keep an eye on that. So when you feel that, deciding, do we need more meds, do we not? And that's a conversation that we have. So I didn't pull this up. I was going to pull up the Oprah flash mob, but then it started yelling and everyone was like, why is Oprah on the screen? But so how I like to describe this is kind of like a flash mob. So before we used to have these flash mobs, if you ever saw them on YouTube or something, where you have just one neuron. So that red neuron is that bad neuron that's looking to cause a party, cause trouble, and by themselves they don't cause too many problems. And so if your doctor has ever recommended an EEG, which is a brainwave study, we're usually looking for signs of that bad neuron, that like little tiny group of bad neurons. And so those are not when you're having a seizure, it's saying, okay, is there any evidence that you have some neurons that are like ready to cause a party over there and they're ready to get excited? And we can see that in EEG even when you're not having a seizure. What happens with the seizure is those neurons start recruiting that one party that one dancer starts recruiting the nearby dancers, and then suddenly it causes symptoms. And then as it spreads to the whole train station, that's when people have a convulsion. So once you have your whole brain involved, or once somebody has the whole brain synchronously firing together, that's when people have a big seizure where they fall to the floor. So a lot of times when people are like, they'll ask you, or somebody says, did you have a seizure? People are usually just thinking about seizures when they fall to the floor and have a convulsion. But in reality, a lot of times people have smaller seizures that if we as your doctors and the people that are taking care of you on the medical side aren't asking the right questions, you may say, no, I've never had a seizure. But then if I say to you, have you ever had twitching of your hand that then goes to your arm and then goes to your face? You're like, oh, wait, that's a seizure? Or have you had these symptoms? And a lot of times it's kind of dictated by where that tumor was, or where you had surgery. So this is what a seizure looks like. And so when we're looking at your EEG and we're looking at the brain waves, there are two types of epilepsy in general. They're kind of a generalized epilepsy, but for patients that have a history of brain tumor, or they have a prior brain tumor, or there's a brain tumor there, there's one area of the brain that's irritable because of that tumor that was there, or where that surgery was. And so that one area is where we often look for the sort of seizures to come from. We'll often look for these, I don't know if this is, yeah, so here, these are little signs. So if you don't know anything about EEG, which you definitely don't have to, something that is it can stand out from the background. So all of this is looking at your brain waves, but what we're looking for are these little discharges that are right here that are saying, hey, this area is a little bit, that's like that red little dancer. It's like, it's just saying, hey, I'm ready to fire. I'm really excited. I want to go and party and cause problems. And then what happens is here you can see when those discharges start coming up and they're repetitive, that's when you have a seizure, is when they're repetitive, they start recruiting, it goes on for 10, 20, 30 seconds, a minute, 2 minutes, and then the brain relaxes. So a lot of times when people have seizures that are motor seizures, meaning they involve some sort of positive, they're like twitching or something, afterwards they can get really weak afterwards. And that's because the brain was like fire, 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 and they have all this twitching. Then afterwards, it's really hard to recover from that, and that's called a post-ictal weakness, or it's a weakness after the seizure. So I'm just gonna, I'm not gonna be able to play this, I think, because the link's not on there. So there is, I wanted to show this video. So there's this woman on QVC, it's readily available, about a seizure, or Mitch McConnell, if any of you saw those videos, those were seizures. I don't know who the doctor is taking care of them, but he needs to give them more medication. And he is, so where you have this speech arrest, where it's sort of this fumbling, it's in the beginning, there's a little bit of speech problem, and there's sort of this, I can't really act it out very well, but there's a little bit of speech hiccups and a little bit of difficulty, and then there's a speech pause. So that's what we see with seizures that come from the speech area, where the firing is sort of disrupted and the brain is trying to recover, and then you have that, and then as it spreads, it becomes a complete speech arrest where somebody cannot speak. So we see these different types of seizures, but what happens, what do we do, or what can you do as a caregiver or somebody that's watching this, and how can you best protect the person that you love, or what do you do if you feel something come on? Well, I would recommend that you ask your doctor specifically, because different seizures can act in different ways. But for most patients, if you start to feel a seizure come on, the safest thing to do is to go into, if you're alone, especially if you're alone, is to go and lay on the floor in a safe space. You may go and lay on the floor and be like, and you say that you feel this, you get it, sometimes people describe a very typical sensation of a stomach dropping, and then they get a weird taste and a weird smell. They get that feeling, and you may go lie on the floor and be like, why am I lying here? Nothing else is happening, but at least you know you're safe. Because the risk is if it progresses, if that seizure spreads to a convulsion, if somebody's standing up, you're at risk of falling and injuring yourself. Sometimes what we'll recommend is also if you see somebody else having a seizure, the important part is that you do not need to put medication in their mouth right away. Sometimes we'll prescribe medications as a rescue medication that may be something that your doctor's recommended. You do not need to give that to them right away. If they're having a convulsion, which is a seizure where they go, ah, and then they start stiffening and then it's shaking and they're on the floor, do not feel like you need to go in and get the medication in their mouth at that time. The reason why we give those medications is to prevent clusters of seizures. meaning once somebody is coming back to is when you can actually give that medication to prevent multiple seizures back to back. In that moment, if you see the person that you love start to have a seizure, first of all, you have full permission to call 911 because it is scary and awful and it is frightening to see. That being said, you don't always have to call 911. If you see that this is a typical seizure, you see that they're coming back to their normal selves within a minute or two, and they're acting like they typically do with their seizures, in that moment, the best thing you can do is guide them to the floor, turn them on their side, and the seizure will stop after a minute or two. That being said, seizures feel like they last 20 minutes when you're watching someone have a convulsion. And so if you feel like it's lasting longer in any way, or you want to call 911, I always tell my patients you have full permission to call 911 anytime, because it is awful and scary to see somebody have a convulsion. But most of the time, if you turn them over on their side and then afterwards they're coming back to, in most scenarios, talk to your doctor, but you may be able to keep them home. And you may not necessarily need to call 911, but I would recommend asking your doctor about that. I said ask your doctor like 12 times, because I really want you to ask your doctor about that. So if you have a brain tumor or have had a brain tumor, how likely is it that you have a seizure or will have a seizure? Of all patients who present, or all people who present with a first-time seizure as an adult, up to 38% of those patients have a primary brain tumor, meaning it's not a metastatic brain tumor coming from somewhere else, and then 20% of patients with a metastatic brain tumor. So this is relatively common for our patients with brain tumors, and this is why I'm involved with the Brain Tumor Institute, is really to be able to help out, especially when there are questions from the patients or family, but also from the doctors and my colleagues. How often are the brain tumors the cause of seizures? Is about 10 to 15% of patients who have seizures as adults. So that means 1 out of 10 patients that have seizures that started when they were an adult also have a history of a brain tumor. So this is relatively common for our patients. In patients with people with brain tumors, seizures are the presenting symptom in 20 to 40%. And a further 20 to 45% of people with brain tumors will have a seizure during the course of their disease. What this means is that it is common that people will come to the emergency room with a first-time seizure and never have another seizure during their lifetime. But there also is a possibility that they didn't have a seizure initially and they may have a seizure later on. And that's why we're always thinking about this as your treating team and making sure that we're keeping this in mind as we adjust medications. The likelihood of a seizure occurring depends on the tumor type. And this is really related to the grading of tumor. What we know is that patients with a lower grade tumor in general are at a higher risk of having seizures. So gangliogliomas, DNETs, low-grade gliomas, although low-grade gliomas, what we now know, thanks to Dr. Horvinsky, who's going to present, is that this is more related to some of the genetic makeup of the lesion itself. And then also for the higher grade lesions, it's less common at about 25 to 50%. For meningiomas, about a third of patients have seizures associated. So just to kind of highlight what does this mean is that the location of where a lesion is sitting really is associated with the likelihood of seizures as well. The gray matter is where those neurons are sitting, and that's where seizures come from. And so when I'm talking about the neurons firing, it's typically this outer layer of the brain tissue that when a lesion is involving this tissue, they're at a higher risk of having seizures as well. Okay, so I could definitely put you all to sleep going through the data, going through the details of this, but what I wanted to say here is this is our approach to anti-seizure medication in general, and how we use our anti-seizure medications. What I want to just comment on is that our medications act in different ways. So for people who need multiple medications, your doctors are thinking about this in a way that it's called rational polypharmacy, which really means we're thinking about what are the different ways that these medications work, how do we use the different targets, use them together in unique different ways that we can help you and help other people be able to become seizure-free or have less seizures. If somebody is calling, because I feel like if it was my doctor and I was calling with more seizures and I was like, they're giving me another medication, what are they doing? Do they even know what they're doing? I don't understand why. It feels like I'm I'm just a lab rat and they're just testing out these different medications. But the reality is the different medications are acting in different ways and people respond in different ways to these different medications. So a lot of times there is an element of trial and error, but there is some rationale behind that, which is also important to consider. So how do we treat seizures related to brain tumors? So we know about 1/2 to 3/4 are well controlled with medications. And for patients who do not have their seizures well controlled, we think about other options. Depending on the type of brain tumor it is, sometimes we will think about additional surgery, or we'll think about surgery as a way to help someone who's having seizures despite multiple medications. Most importantly is the conversation with your doctor, and making sure that you're having the communication open and talking about your concerns and what questions you have. And also, I just wanted to highlight the seizure first aid that I mentioned. So most importantly is just to stay with the person until they are awake and alert after the seizure. Know that that can take a while for them to be completely awake and alert and responding. If they have a larger seizure like a convulsion, that can take up to 30 minutes. Make sure you keep the person safe. So usually what that means is if that person, let's say that you're at the dinner table, you notice they're having seizure, if you guide them to the ground, move everything that's sharp out of the way, and then they will have the seizure, and then in about a minute or two, it'll be over. Turn the person onto their side if they're not awake and aware, and then you should call 911. So these things that I mentioned, if the seizure lasts longer than 5 minutes, they don't return to their usual state, if they're injured, pregnant or sick, if they're having a lot of seizures back to back, if it's a first time seizure, difficulty breathing, or the seizure occurs in water. This is the reason that we don't recommend that people take baths, is because you actually can drown with a seizure. You should not restrain them. So a lot of times people will, especially in bed, they'll try to hold their arms down. The reality is that somebody can have a dislocated shoulder from that because of the tension put on the shoulder. Do not put any objects in their mouth. So there used to be this old wives' tale that you should put a spoon in their mouth to make sure they don't swallow their tongue. Nobody will swallow their tongue, so you can just don't put anything in their mouth. I feel like I've said this quite a bit, but I think it's really important to have these conversations with your doctor. Everybody is unique in their goals as well, and it's important to talk about what is important for you. For some people, a seizure that may just be twitching of the thumb may be something that is a reminder of what's going on, and they just want these seizures to go away. For some people, they may say, hey, this is going on my thumb. It's not bothering me. I'm fine. I don't want other medications. It's really about deciding what is your goal with your doctor and making sure that that goal is clear and having that clear line of communication. Thank you. Oh, here's my Oprah.
Thank you, Dr. Chancellor. We have some minutes for questions. If you have questions, please write them down, and we're happy to collect them. And then Chris will help moderate them. Chris, do we have anything online?
Yeah, so we did get one question through the chat. Are there any benefits of taking supplements such as vitamin B6 while taking levetiracetam, also known as Caregiver?
So levetiracetam is a medication that we often use for seizures because if somebody presents with a first-time seizure in the emergency room, we know that we can get a lot of that medication into someone's system very quickly to a therapeutic dose. It doesn't have a lot of interactions with other medications. People generally tolerate levetiracetam well, with the exception of some mood irritability and mood changes. So if you Google Keppra or levetiracetam, there's Keppra rage. Keppra rage is very rare for people to become homicidal, suicidal, and aggressive. However, there is a more subdued form of that is actually relatively common, where people can get more quick to get angry, more irritable. I've had partners send me messages and say, hey, listen, I'm considering a divorce. And I was like, well, let's stop the levetiracetam first before that. So these mood changes and irritability are very real, and they're more subtle than things like, we can't check that on a lab test. So it's really about that sort of keeping an eye on it. With that in mind, there was a study that was done in children that showed that vitamin B6 was helpful in some of the irritability. The problem is that we can never study that because drug companies will never pay us to study a vitamin. So what we do see clinically is that there are a lot of patients that I see benefit from vitamin B6, usually it's 100 milligrams daily, that can help with some of the irritability and mood side effects with Keppra. It's not always 100%. I usually recommend a trial of it. We see how people do, and if they're still struggling, then we talk about switching to another medication.
Can you feel a seizure coming on?
So that is a very good question. For some patients, the answer is yes. And it depends on, when I was talking about where the brain tissue is firing and misfiring, that really tells you if you can feel the seizure at the very beginning. Some people, especially in the left temporal lobe, they have no warning at all, and suddenly they've lost awareness and they didn't have any precipitating symptoms before that. Some people, if the seizure is coming on in the part of the brain that controls their hands, for instance, they'll feel a feeling and then they'll start to have that twitching. It really depends on the individual. Some people have a warning and some people don't.
This is kind of a tough one, but do you have any general recommendations for driving while living with a seizure disorder?
Oh, that is a very tough one. So here's what I can say. So the state of Illinois, the law is that you cannot drive for 6 months after having an episode of loss of consciousness. That is the state of Illinois driving law. There is a caveat with the physician's discretion. Now, please don't harass your physician to use that discretion and let you go and drive. But where that can come into play is if we have a patient that, so if I have a patient that I know has been stable for 2 years on Keppra 1,000 twice daily, like I know that they've been doing really well. And we lower their medication to half of that dose. But I told them not to drive. Usually I will not let them drive around that lowering period. So let's say for a month, so we're not gonna let you drive during that period. They're at home and they have a seizure. I would say to them, well, no, you were seizure free on that full dose. We just need to go back to that dose and you can go back to driving. So there's caveats to that. But it's not really, I think where it gets challenging is if there is a first-time seizure that led to the discovery of brain tumor. Then somebody had surgery. Then they're on medications. It's very hard to say, well, I know that you're going to be seizure-free, go ahead and go back to driving. That's really a conversation to have with your provider. But a lot of times, if there's some reason why there was a seizure, we usually can justify going back to driving relatively quickly. But there's a lot of challenges that come into play too.
Do patients ever go down on their dose of their anti-seizure medication?
Yes, definitely. And I think that's really where the thing that, what we know is that for patients with gliomas, we know that radiation, temozolomide, and surgery are also part of the best things that you can have to help with seizures. So we want to constantly reevaluate. So at every visit, along with the oncologist and the neurosurgeon, we're talking about what is your state today? Every time it's like, well, how are your seizures today? But also, how is your treatment going? What other treatment have you had? And how can we make sure that we're keeping that in mind and thinking about lowering medication?
Great, thank you. Do we have any data to support the benefits of the ketogenic diet in regards to seizures?
Yes, so there is data about the ketogenic diet that suggests for epilepsy in particular, a modified Atkins diet has been helpful. And we have somebody that specializes in from the epilepsy clinic that specializes in the ketogenic diet. What I don't know is the relationship with brain tumors as well, but I can speak on the epilepsy side that we have seen data that it's beneficial. And it doesn't ever replace medication, it just supplements.
Any other questions?
Okay.
Thank you.
Thank you so much.
Okay, before our third speaker, anybody want some more chicken? Salad, anything? So we're rounding out with our third speaker, and I'm very pleased to announce that we have Dr. Lurie Cancer. Dr. Korbensky is going to speak to us about predicting and preventing venous thromboembolism in glioma patients. But he is a professor of neuropathology and neurological surgery. Dr. Horbensky is the director of the neuropathology at Northwestern and performs clinical and research duties. He is a leader of the Northwestern's Brain Tumor Spore and oversees the Northwestern Nervous System Tumor Bank. Dr. Horbensky's mission is to improve the care of patients with gliomas and meningiomas. So please welcome Dr. Horbensky.
Thank you very much. Can everybody hear me?
Yes.
All right. So what I'm going to talk to you today about, does this advancer work? Very good. You may have heard the term bench to bedside. That's a term that gets overused a bit in biomedical research. The idea is that basic laboratory-based discoveries are then used to hopefully translate into better clinical care. But really, it's a two-way street. It's a symbiotic relationship because patient-based observations can also be brought into the laboratory and studied in more detail, ultimately with the goal of bringing it back to the clinic for better care. And this project here is an example of that. Now, adult-type diffuse gliomas, we call them now adult-type diffuse gliomas because these are tumors that have a molecular genotype that is more commonly seen in adult patients. So even a child can have an adult-type diffuse glioma, it's just less common. There's about 20,000 of them per year in the United States that arise every year in the US alone. There's three major subtypes here. It's oligodendroglioma, IDH mutant and 1p19q co-deleted, grades 2 through 3. These terms are probably familiar to a lot of you. Grades 2 through 4, IDH mutant astrocytomas, and grade 4, IDH wild-type glioblastomas. Now, the survival for these patients varies, as you know, by molecular classification and histologic grades. So if you just take all comers together, the IDH wild-type glioblastoma patients have the toughest survival. The IDH mutated 1p19q co-deleted oligodendrogliomas, those have the best survival, and the IDH mutant astrocytomas are in between. But really, if you look at, and we know this now, that even histologically, if a tumor looks like a grade 2 or even a lower grade 3 tumor, if it's IDH wild type and it has some other molecular features of a glioblastoma, those patients still end up having outcomes similar to a classic glioblastoma. That's why we now use molecular diagnostics in many cases to augment or supplant histopathologic diagnoses in these patients when we're doing our neuropathology workup. So we're catching a lot of cases that we used to be underdiagnosed and undergraded. Likewise with IDH mutant tumors, there's a split. It's not a great split between grades 2 and 3 in terms of survival, but the grade 4 tumors are more aggressive, although it's still better, relatively speaking, than IDH wild type tumors. And the 1p19q co-deleted, grades 2 and 3, there is a split according to certain histopathological features. All right, with all that, what's the point of laying that all out? Is because since, as you can see, the IDH mutation is central to the workup of gliomas now, and it's been that way actually for quite a few years. In my practice, of course, I don't see patients directly usually, but I do see the tumors and I see the molecular reports, and I have to integrate the two together to produce a unified diagnosis. And after a few years, I gradually noticed something kind of unusual. These cases I'm about to show you are real cases. 65-year-old woman who had a right frontal mass. As you all know, radiology does everything backwards, so that's actually on the right. And it was resected, and under the microscope, it had all the other features of a glioblastoma that we usually see. But one thing that was striking was how many of the blood vessels were clotted off. So this is a banana-shaped blood vessel. This part here is open, but this part here is completely plugged up. That dense pink material is what a clot looks like on our basic staining. And what's clearly happening here is that this clot occurred, the blood is backing up, and it's starting to leak out into the brain tissue. This tumor was shot through with all of these little miniature blood clots. You can only see them under the microscope. And it lacked the canonical IDH1R132H mutation that we know. So it was an IDH wild type tumor, and the patient, she unfortunately had a bad outcome. Second example of a younger fellow who had an enhancing mass in his left frontal lobe that was resected. And at lower power, you can see there's plenty of necrosis here. And down here, this is what necrosis looks like, it's all dead tissue. And at the higher power, we can see all these knotty vessels. Just take my word for it. These are blood vessels. They're surrounded by tumor cells, but these are actually blood vessels. So they're not cancerous themselves, but they grew in response to the tumor. Now, what you don't see in any of the blood vessels or any of those big old clots like we saw in that other case, this patient was immunopositive, right, or contained the IDH1 R132H mutation. So he had a much more protracted clinical course. So that was an IDH wild type grade 4, IDH mutant grade 4 astrocytoma. So I gradually, and again, I didn't have any priori hypotheses, meaning I didn't seek to connect the IDH mutation with clotting of all things. It just, after a couple of years of looking at these cases and integrating the diagnosis, I gradually became aware that the IDH mutated tumors tended to not have these blood clots within the tumors, whereas the IDH wild type tumors almost always did. And this ultimately led, this was a few years ago now, it led to the first study that described this inverse relationship between the IDH mutation and blood clots within the tumors. And with the help of a good friend and colleague of mine, Matthias Snudrol, who's a neuropathologist like me at New York University, both in our cohort and the validation cohort from NYU, we found that whereas the majority of IDH wild type patients did indeed have lots of blood clots within their tumors, the majority of the IDH mutated patients did not. Now, that is interesting in its own right. But from a patient perspective, and why I'm presenting this to you today, venous thromboemboli. So there's a big problem with blood clots, and many of you may have, or your loved ones have experienced these blood clots, where the leg or even sometimes the arm can get plugged up, swollen, tender, it hurts. Now that's bad enough, hurts to walk, it's really inconvenient, but if those clots break off, they will scoot through the big pipes back to your heart. It won't get stuck in the heart because the blood flows too fast and the pipes are too big, but then it goes out from the heart to the lungs and gets plugged into the lungs. And if it's a big enough clot and it doesn't dissolve on its own, it causes a stroke or an infarct in the lung. That's called pulmonary embolism. And that can be debilitating. I mean, you've just, destroyed a part of your lung. And if it's bad enough, like in this patient, you can have what's called a saddle pulmonary embolus. So it's a big enough clot that blocked both of the main arteries supplying both lungs. That's sudden cardiac death. Now, it turns out that glioblastomas, or gliomas in general, are one of the most common cancers to cause. Any kind of cancer can do this. Any kind of cancer can cause this kind of hypercoagulation, but gliomas are one of the biggest offenders. Well, what we found out, though, was that it only really mattered, that only held up in both of our cohorts if it was an IDH wild type tumor. If it was an IDH mutated tumor, none of our patients had venous thromboembolic complications, which was a really, really striking finding. Now, I won't get into the weeds too much on this, but I have to a little bit because it's a potential blood test that may be coming your way before long. There's something called tissue factor. It's also called clotting factor 3 or thromboplastin. It's a protein that's highly conserved in evolution. What we mean by that is very ancient organisms have this protein. And the general rule of thumb in evolution is the more ancient the protein is, the more important it must be for your basic life. And so even horseshoe crabs, which are 450 million years old, have a version of tissue factor in their bloodstream, so to speak. So it's a really, really important protein. In fact, you can't live without it. You've heard of hemophilia, where you have deficiencies of clotting factors. There's no such thing as a hemophilia with tissue factor deficiency because they never even make it to birth. So this is a very complicated clotting cascade. For those of you, we have to memorize this to get through med school, so feel free to pity us. Because God knows how people figured this out. But anyway, the tissue factor combines with factor 7A and converts factor 10 to factor 10A. And that's the critical rate, what we call rate limiting step, because once that happens, the rest of this horrible looking clotting cascade runs itself to completion in the form of a stable fibrin clot. So if you want to regulate how much clotting happens, this is where you do it. That tissue factor complex is a great place to start. And what we found out was that regardless of the grade of the tumor, our IDH mutated tumors consistently produced a lot less tissue factor than the IDH mutated tumors produced a lot less tissue factor than the IDH wild type tumors did. And this translated to even the immunostaining. So the brown means a positive stain. Most of our glioblastomas that are IDH wild type are roaring positive for tissue factor. Virtually all of our IDH mutated tumors are completely stone cold negative for tissue factor. They just don't make it. Now, the reason why that in particular was interesting is there's been a lot of data across a lot of different kinds of cancers talking about the production and release of this tissue factor by cancers into the bloodstream. And it can be any kind of cancer. It can be ovarian cancer, it can be, blood cancers, it can be lung cancer, anything. Some cancer patients are walking around with up to 1,000 times the normal amount of tissue factor bouncing around in their bloodstream. And so if you think about it, those patients are time bomb ready to go off because they've got massive amounts of a very powerful procoagulant in their bloodstream, and they're ready to have a massive thromboembolic event. And what we found was that our cancer cells, the IDH wild type glioblastoma cells, did indeed produce a lot of tissue factor, including this tumor that came from somebody from Mayo Clinic, actually, GBM12. And interestingly enough, you can see how powerful the tissue factor production is in this. The bigger, thicker marker look, that means a lot more tissue factor than the others. That patient, so that one really stands out, doesn't it? Well, it turns out that patient died of a pulmonary embolism. So there you go. And then so that's just in the cells alone. Then my postdoc at the time, Dustin Unruh, he just took the culture media, in other words, not the cells, just the culture media, and tested how much tissue factor the tumor cells were kicking into the culture media, and found out that, yep, GBM12 was the biggest one. That just spat out tons and tons and tons of tissue factor into the culture media, and so did its other IDH wild type GBM brethren, but the IDH mutated tumors did not. And that all led to this follow-up study that we just recently published. In fact, when I moved here in Northwestern in 2015, this was one of the very first projects we got started with our biobanks. So it's taken that long to collect all these patients, all the data, all the tissues, and follow them over time to see how they did, specifically whether they had blood clots or not. And what we found was, sure enough, that over time, the majority, or at least half of the, if they live long enough, the IDH wild type glioblastoma patients will end up developing at least one thromboembolic event. Very few IDH mutated patients do, though. Even if you follow them out to 4 years, their overall risk is less than 10%. And we don't have to go into too much details with this, but we were able to associate that with tissue factor. So the red means more tissue factor expression. Sure enough, like we had already shown before, the IDH mutated oligos and astros are pretty cold, but the IDH wild type GBMs tended to be a lot warmer when it came to tissue factor expression. And that associated with, it was the highest levels, the tumors that kicked out the most tissue factor, those are the ones that were at the greatest risk of clotting, of causing a clot. And the same thing happened when we were assessing tissue factor in the blood. So at the time of surgery, we would draw blood. Some of you may know that, if you consented to our research protocol, we would draw the blood and we would take a portion of that blood and assess how much tissue factor was in that blood. Well, at the time of initial diagnosis, before the first surgical incision was ever made, a subset of our patients had super high levels of tissue factor. And it's just defined as this particular cutoff that other people had determined. Once you get a level beyond 2.0, don't worry about the units, those patients are really ready to blow up. And that's exactly what we found. So in that subset of patients, they had a very rapid time to developing a thromboembolism. Just weeks or even during the immediate postoperative period, they were having severe problems with blood clots. And the same goes for another blood test that you may or may not be aware of, D-dimers. That one's not quite so surprising, because we've known for a long time that actually can predict blood clotting. And it's no surprise that the glioblastoma patients were the ones that had the highest levels of circulating D-dimers at the time. And that really correlated nicely, so highest, intermediate, and lowest levels in all of our brain tumor patients. But then on top of all that, what we were able to do with our cohort was assess a lot of other clinical variables. So we were talking about patients who have elevated body mass index, hypertension, white blood cell count, advanced patient age, all of those things, to integrate all of these things, 7 risk factors that increase VTE of probability. 3 that decrease the probability of a thromboembolism. That's IDH mutation, MGMT promoter methylation, and it's surprisingly hypothyroidism. Who would have guessed? And we were able to create a thrombosis prediction app. In fact, it's available online. I can send it to anybody if you're just curious to muck around with it. It's free. And what it basically shows is it looks like this. And all you have to do is take and enter little radio button choices for a particular patient. Say, all right, your patient does your patient have hypertension or not? Hypothyroidism or not? Asthma, a prior history of VTE for any reason, patient age, body mass index, all these other things. You just punch it in, and as soon as you complete all 10 variables on this little website here, instantly your projected risk of thromboembolism at 1, 3, 6, and 12 months pops up. And we were able to validate this, so not just at Northwestern, because it worked at Northwestern, we validated it with cohorts from our colleagues at Duke and at UCLA. So we had them run the same app on their data, and it ended up producing similar results as ours. It does a pretty good job of predicting who's at risk. So the point being then is that this online risk calculator can really help identify patients who are at the greatest risk of, and what's the point, and why am I presenting this here? Because right now, we really don't know who should be put on anti or blood thinners, antithrombotic, what we call antithrombotic prophylaxis. We can't just say blood thinners because that doesn't sound fancy enough. I've asked about 10 different neurosurgeons and 5 or 6 different neuro-oncologists their opinion on when a patient should, how do you manage this? Everybody has a different opinion and everybody's convinced they're right. And the reason for that is because there's never been a single study in the literature that establishes best practices for who is at greatest risk and whether or not you should try to prevent a clot before it happens. Because a lot of physicians will say, well, we just wait to see if they develop a blood clot and then we put them on. Okay, you can do that, but sometimes the first clot's the last, if you take my meaning. And besides which, it's really debilitating. And even if the patient survives it, if they infarct half their lung, that's likely to shorten their overall survival, and certainly hurts their quality of life. Not to mention that now you got them coming in from yet another hospital admission, right? I mean, you guys, brain tumor patients see enough of the hospital. They don't need another reason to come in. So what we're trying to do now is figure out, in a clinical trial we're trying to get together. In fact, actually next week, I'll see if the grant gets funded, because it's being discussed at the NIH. Whether this risk calculator can predict patients who are at higher or lower risk and then assign the high-risk patients to blood thinners up front before they even have a clot. Plus, on a regular basis, when they're coming in on an outpatient level, just keep drawing and checking for tissue factor levels and D-dimers on a regular basis. So let's say somebody comes along and they're fine, their risk is low, projected risk is low, and then you keep drawing their blood. It's, tissue factor and D-dimer levels are low, 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 low. All of a sudden they spike. Maybe they spike after treatment, maybe they spike after recurrence, something like that. Are those patients then likely to develop a clot in the imminent future? And if they are, if we find out that they are in the clinical trial, then we'll know, okay, that's part of the best practices. Draw the blood on a regular basis, just part of standard outpatient testing. If their levels spike, that's when you put them on the blood thinner. That's when you put them on the oral anticoagulant. So that's really what this trial is all about, is identifying new adult type diffuse glioma patients, assess the risk up front with this online app. Like I said, it's free, it's totally free. Are the patients at higher risk, yes or no? And if they are at higher risk, then we're going to try something called the Pixaban. Some of you may recognize that. It's a direct oral anticoagulant, very safe, very well tolerated. And in any event, we're going to follow all the patients, screen them for VTEs on a regular basis, and draw their blood and assess this tissue factor and D-dimers. Now, we're doing this. Priya Kumthekar is my primary neuro-oncologist here at Northwestern, who is taking the lead with me on this. But it always takes a team. And so Masha Kokonursky is the biostatistician here at the Lurie Cancer Center who helped us figure out, okay, what are the cutoffs? Well, how do we count high versus low risk? What counts as high versus low risk? How many patients are we going to need to enroll, and all that sort of thing? And Mark Malkin is actually the chair of neuro-oncology at Cleveland Clinic, and so he was very enthusiastic to join us on this project. And Katie Peters at Duke, she's a neuro-oncologist. So it's a lot of fun, and it's just an example of serendipitous observation under the microscope. Nobody in their right minds would have connected IDH mutation of all things to clotting. And here we go. You know, this is, it takes many, many years for it to mature to this level of research and to be this close to a clinical trial. But I couldn't have done it without the help of a lot of tremendous people in my laboratory, especially Katie McCourtney, my biobank manager, because she played an absolutely essential role in getting all these other cohorts from UCLA and Duke and everybody involved. It's like herding cats, you know, trying to get external validation cohorts. You would think it'd be easy. Trust me, it's not. So I was really grateful for that. Lots of other people to thank and funding over the years, especially as was indicated, our P50, this is the grant number for the brain tumor spore, and the Brain Tumor Institute has been tremendous in providing philanthropic support for this research as well. I tweet out a lot on Twitter, or what they call X, I don't care what they call it, it's still Twitter. It's like, I still call it the Sears Tower, you know, it's just, so thank you very much, and I'll take any questions.
Thank you, Dr. Werbinski. If you have questions, please write them down. Chris is going to read some from the chat room.
So far we've had one question from the chat. Do you see age being a factor to patients needing blood thinners?
Yeah, so one of the things we found is that advanced patient age, and the way we did it is if for every year of increasing age, slightly increases your risk, your additional risk over the subsequent year of developing a thrombosis. So if you're a 50-year-old, you've got a certain risk. If you're a 70-year-old with the exact same tumor, you've got a higher risk.
This is somewhat related to your presentation, but do you have any causes for brain tumors and any methods for prevention?
The only thing I can tell you is exposure. The only environmental exposure that we know of for sure that's associated with increased brain tumor risk is high doses of ionizing radiation. And I'm not talking about the kind you get in dental x-rays or anything. I'm talking like Hiroshima bombs and things like that. And we know very well, but it takes a long time. So those patients would develop glioblastomas and other kinds of brain tumors 10, 20, 30 years later. But even for whatever sort of the Chernobyl disaster, that did not result in any increased brain tumors locally or worldwide, which is really was a surprise. That did not give enough radiation exposure.
Any other questions?
All right.